we're turning now to the cultural and religious antecedents of palliative care as we know it today. And I've already built up the foundation of the religious attitudes and practices that were contributing to these institutions and ideas that develop. But in the 19th century, we see all the forces coming together that create what comes to be known as palliative care, hospice care. And we're going to see when we get into the founders of palliative and hospice care that they carry all of these elements within them and their attitudes. And so religion remains very important. But in the 19th century in particular, we really see, it's earlier than this, but in the 19th century, we really see it developing, that medicine is making huge strides. And you will, of course, all know about this with finding about vaccines, all these new treatments that become available. And so we see the role of the doctor becoming much more important. And so this then comes into kind of dialogue and sometimes into conflict with the role of clergy and religion and family, particularly in relation to illness and the death and dying, because this had previously been pretty much left to family and religion to handle. But we see medicine making its way much more center stage at this point. So I want to give something of an overview at this point. Now, obviously, this is a huge area of history. There are many, many forces happening in the 19th century that many of you will be familiar with from other courses or courses with me, that we see the Industrial Revolution, urbanization, a lot of land dispossession in countries like England and in Scotland, mass immigration out of those areas, often to places like Canada. And we also see changing gender roles. So there's a huge cultural flux going on at this time period in the Western world. Another very important factor is demographic change, which is partly related to increasing knowledge in terms of medicine. And so we see the European population doubling and the emergence of chronic diseases like cancer and tuberculosis as the most common causes of death. So if we think back to earlier lectures, in the medieval period, it was diseases like the plague and cholera and these diseases that happened very quickly were more common and often that actually kill children. But we see emerging in the 19th century chronic diseases. And so this has a lot of implications for dealing with death and dying, because this becomes a much more prolonged process. And of course, in our time period, this is even more the case. And so both religion and medicine have to kind of scramble here to deal with the changes that are happening with in terms of how people are actually dying. And so we also see, in reaction to these cultural turmoil, particularly the impact of industrialization, the Romantic movement. And many of you will know about this from English courses or our history courses, that this is a reaction against what's seen as the kind of bloodless approach to life coming out of science and the Industrial Revolution and the way that workers are being treated and so on. So there's many, many things that come out of the Romantic movement, including really beautiful poetry and literature, but it also impacts ideas around death, and it colors the larger Victorian culture. So I have included some material on Victorian attitudes to death and dying, and it was very interesting to me when I was preparing this section of the course to see how these attitudes are treated, which is generally as though they're Gothic or creepy, as is often used, which I found very perplexing. But what we see in the Victorian period is it's sometimes been referred to as a death cult. I don't think that's really accurate, but there was a great elaboration of death ritual. Now, obviously, religions all have death rituals, as I've talked about, but we see in the Victorian period all sorts of memento mori, the importance of the graveyard, all of these things really gaining gaining ground, partly because, again, deaths often are lingering. And so we see the culture reacting to that. We also see in the Victorian period the idea of the woman, at least the upper class woman, as the angel of the house. So the role of women around death, dying, and mourning is very important. And Queen Victoria is often used as an example that she set the template in her reaction to the death of her husband, in which she was, as far as I know, in mourning the rest of her life. So we also see the growing role of medical doctors alongside clergy. And as I already stated, this does exist in a kind of tension, and this continues into the present day when, of course, medicine is now at the center. And in some ways, palliative care reacts to this fact. Is it appropriate that medical doctors should be at the center here? And what we're going to see in modern hospice palliative care is a kind of combining of two worldviews, and that's what makes it so distinctive. But at this stage, we're starting to see medical doctors taking at least some interest in this process. And so we find the term palliation first appears in the sense that we would understand it in the writing of a medical doctor named Richard Rees. So we start to see medical doctors, not many, and they don't get a lot of traction, but writing on death and dying. This doesn't really come into mainstream discourse until really the 1970s, actually, in Western society, but we start to see the first glimmers. As I said, religious ideas continue to be extremely important in relation to death and dying, as they still are. And in the Victorian period, ideas of a good death are impacted particularly by evangelical Christianity, which is gaining in popularity at this time. And this is not evangelical Christianity in the American sense that we talk about it today. This is a particular style of Christianity emerging out of Anglicanism in England and very much influencing countries like Canada. That is much more like a form of Methodism, which is dedicated to things like social justice, equality, the social welfare, and this then extending to care of the dying and ideas about death. So evangelical Christianity has that very strong activist kind of energy to it. So the basic idea was that death should occur at home. So again, that idea of the Victorian home and the nuclear family, with farewells to family and devotions and prayers. So again, putting religion and family at the center of death and dying. And it's interesting to see that when people are surveyed, the majority of people say they want to die at home, and this is rarely the case. Well, it's becoming more common in Canada, partly because of the palliative care movement. We can look at this more towards the end of the course. But certainly by the 60s and 70s, most people in countries like Canada were dying in hospital. And so in many ways, palliative care comes out of a critique of this. Is this actually the way people and their families want this to happen? Certainly in the Victorian period, the idea was that you would die at home. And I know within my own family, this was still very common into the 1910s and 20s, where you would have the wake, the funeral at the church, but you would have the body at the house. So this would have been the common way of dealing with it. So there's been a lot written about sort of contemporary ideas around death, where the funeral home takes over and these professionals take over. But certainly during this period, it would have been in the home and overseen by clergy. So ideally, the person was awake and lucid. Again, this is very common in religious traditions, that idea that you don't want the person to be completely unconscious. This is true in Buddhism as well. The idea that you want them to be lucid so that they can participate in religious rituals and that they can speak with the people around them. Now, the attitude to pain is very specifically religious, and this is where it does come into critique. And so we're going to see that the medical profession moves in here. So the sort of overarching religious ideal that pain should be dealt with stoically as a final test of faith. Okay, so this is a very religious view coming out of Christianity, often equated with, Jesus' suffering on the cross. So I want to be careful here, because religious traditions often give meaning to suffering, whether it's physical or mental. So there's nothing strange about that. But certainly we see the medical profession where we see them starting to use compounds like morphine to deal with pain. And so this becomes a very important part of what's going to become palliative and hospice care. The idea that people shouldn't be in pain if we can possibly avoid it. And the medical profession moves into this space. So I want to turn now to look at homes for the terminally ill in the UK in the period 1885 to 1948, which is when the whole idea of palliative care starts to be developed in the UK. So I'm focusing on England because the founder of palliative care comes from England, and so her context is this, and she was very aware of many of these other approaches. I'm drawing on the work here of To Comfort Always, A History of Palliative Medicine Since the 19th Century. So I'm by no means saying this did not exist in other countries, and I will be looking at a few examples, but I'm focusing on this, as I said, because what we come to know as palliative care emerges out of the UK. So by the late 19th century, as I was saying, we see advances in medicine and public health, and so we see a real growing confidence in medicine. It reaches its peak probably in the 1950s in the medical world. To some extent, the idea that medicine is going to cure all of our ailments is kind of in the air. This, of course, comes to be questioned in the 1960s. But at this time, because of all of its amazing success, and I'm in no way trying to undercut that just medicine was having huge successes and only continue to do so, just if we look at things like polio vaccines, smallpox vaccines, and so on. And so infectious diseases are largely being brought under a certain amount of control. And in some ways, they're a victim of their own success because we see people questioning vaccines now, partly because in living memory, we don't know people who have had these illnesses. So countries like England were increasingly urbanized, as I've already touched on. So we see huge cities like London, and we know that density of population contributes to the spread of diseases like tuberculosis. And so there was a need. And so these institutions emerge from a need for social institutions that are going to deal with these kind of chronic illnesses. And then, as a result, the beginnings of interest in the care of the dying. And this largely remains within religious bounds until the development of the contemporary palliative care movement. But again, we see a small minority of doctors also interested in this and writing on this. As should not be surprising to any of you at this stage in the course, again, we see the central role of women in establishing these institutions for care of the dying, and all of whom came from religious and charitable ideals. So I don't think this is surprising, or maybe it is. It isn't for somebody who studies religious studies. Why else would you do it? This is a pretty thankless task if you're looking for glory or fame or money. So it makes sense that people that did this were driven by sort of higher ideals or humanitarian ideals, emerging often from their religious beliefs. Also, on a practical note, women at the time were largely excluded from the study of medicine. This was also true in Canada until the late 19th century, and so they could not go to university and study medicine. And so their participation emerges largely within religious contexts. And we already saw that in the medieval period, that actually a lot of these women had a great deal of power within a religious context over healthcare. I think there's no doubt that this also fits within traditional gender roles. We can talk about this in the discussion boards, that these types of occupations are associated with what we consider traditionally feminine traits of nurturing and care and so on. And this, of course, is an ongoing issue within healthcare. I do think it's shifting. I know many of us know that there are, I think it's 50-50 now, if not more female doctors, and there are many, many male nurses now. But I'd be interested to know from those of you working in healthcare what the gender split is, and if you do think that these occupations are still gendered. But certainly in the 19th century they were. And so we already saw with Florence Nightingale that women could act within these circles without being seen as transgressing gender norms. So as a result, religion is centrally important in these institutions because the women founding them were religious. And I want to look at these 4 women just to give us a sense of who they were. So I'm drawing on David Clark's book. There aren't a lot of books on this topic. He's one of the few who's written in detail about the history of palliative care. I can talk about him more, but he actually knew the founder. So the first one, Mary Aikenhead and the Irish Sisters of Charity. So I'm just going to read from his book. She was born in 1787 in Cork, Ireland, became Sister Mary Augustine at age 25, and was established almost immediately as superior of a new order known as the Irish Sisters of Charity, the first of its kind in Ireland to be uncloistered. So that's important in the sense that they don't have to remain within the convent. They can go out and act into the world. So they're kind of activist nuns in that sense. So the order made plans to establish a hospital, and 3 of the sisters went to Paris to learn the work of the Notre Dame de la Piété Hospital. And in 1834 in Ireland, they opened St. Vincent's Hospital in Dublin. So after many years of chronic illness, Mary Aikenhead died in 1858, according to Clark, having fulfilled her lifelong ambition. And so the convent at which she spent her final years became Our Lady's Hospice for the Dying in 1879. So we actually see the use of the word hospice in the sense that we would recognize it in 1879. So the next is Jeanne Garnier, who is a young widow and bereaved mother, who together with other women formed an association of women devoted to healthcare in 1842 in France. So they opened a home for the dying the following year, which was, quote unquote, characterized by respectful familiarity, an attitude of prayer and calm in the face of death. And so, again, very clearly a very religious approach to death and dying. This should be completely familiar from the earlier lectures of medieval saints that were establishing these kind of institutions, or even going right back to the early church with Saint Fabiola. So Frances Davidson, who for some reason has chosen a German name, which confuses things a lot, but she founded the first home for the dying in Britain in 1885. She was born in Scotland and grew up in a middle-class religious home with an ethic of service. So she began spending time in London, we're not sure why, and engaged in visiting the sick as part of the work of a mission. So she's clearly Protestant, but she's still coming from a Christian attitude to death and dying. And she, as I said, founded the first institutional care for the dying in London. So the final person here is from the U.S., Rose Hawthorne, who is actually the daughter of the very famous writer Nathaniel Hawthorne. And she had experienced the death of a child and watched her friend die of cancer. So this is very important to note. Often these women, we're going to see this with the founder of contemporary palliative care, comes out of an actual encounter with death and dying in their own lives. So this isn't some abstract ideal. This is something they've experienced. And certainly losing a child would be the most tragic thing a person can go through. So we can see that many of these founders were touched by death themselves. So in 1891, she and her husband converted to Catholicism, and then she divorced her husband and devoted the rest of her life to the care of the poor and those suffering from cancer. So we see here that Christian combination of dealing with the elderly, dealing with people that are poor, and dealing with people who are dying. And so those sometimes come together, sometimes don't. And this causes a certain amount of confusion in the beginning with palliative care of who exactly is it for. And that continues to develop over time. In that documentary that I had you watch, you can see that often people are placed in palliative care now much earlier than they would have been done in the first years of contemporary palliative care. So this is an ongoing kind of moving target, and it depends on the culture it's in. But we can see the early beginnings of what becomes recognizable as palliative care. So we see the founding of the Friedenheim, the Hostel of God, St. Luke's Home for the Dying Poor, and St. Joseph's Hospice in the late 19th century. And we're going to see with the founder of contemporary palliative care that she goes to some of these institutions to work there and to observe and to train so that she can draw on what she deems to be best practice. We'll be talking about that in detail, obviously, when we get to that part of the course. But unsurprisingly, spiritual objectives are at the center. And so, as Clark writes on page 45, accordingly, attending to patients' bodily and mental concerns was felt to be a prerequisite for addressing the ultimate goal, their spiritual needs. So in this, the homes form part of a broader shift in thinking among late Victorian churches, which increasingly recognized that the ability to carry out spiritual ministration was dependent upon taking care of the patient's physical concerns as well. So this, you can see a shift from just the spiritual and concern with the soul to recognizing that you have to, well, that was always there in the corporeal acts of mercy, but the idea that you have to attend to the body as well. Although the ultimate goal was always spiritual. And so when we look at the attitude of pain, we also see this is coming under some kind of scrutiny. And so the chaplain at St. Luke's described this relationship, how hard, how well nigh impossible it is to speak the comfortable words of Christ when the mind of both the sufferer and the minister are taken up with the untended needs of the body. So the chaplain is recognizing that somebody who's in extreme pain is not going to be thinking about religion. They're just thinking about the needs of the body. And so the Reverend Howard May writes, he was one of the visiting ministers to St. Luke's, that we must look upon the pain and suffering in St. Luke's apart from God, for however greatly we marvel at the sufferings which patients have to endure, the most wonderful thing is that Christ is with them in the furnace. Okay, so we start to see a shift in attitude that, particularly as new medications become available to deal with pain, we start to see shifting attitudes within medicine and religion around pain and the idea that we have to deal with pain, and then we can look at concerns with the spirit. I want to end by looking at clinical cultures in the homes, and we're just starting to see the glimmers of medicine, science, technology coming together with religion by the late 19th century. It's still in its very basic form. So during this time period, doctors would often use the word euthanasia in a very different way than we use it today as a term for caring for the dying. And so, as I said, there was the beginnings of the idea of how to make people comfortable at death and dying, and also this controversy over what becomes what we call now assisted death, and palliative care is there right at the beginning. And we're going to see that this is nothing new at all, that this was an ongoing debate, and we can touch on it in the course towards the end. Certainly there's a huge controversy around it when Nipissing Serenity Hospice opened in North Bay, and there were some local doctors who, anyway, I can get into the details of that controversy. But as you will know, palliative care is opposed philosophically to what we call medically assisted dying, and this tension was already there, certainly by the 1940s. So these institutions did not have strong links to hospitals, and they mainly relied on visiting physicians. Now, I have to say, in my experience anyway, this is still often the case because palliative care is more concerned with making the person comfortable and so they can remain lucid. So even now, it's often nurses and PSWs and people like that are doing a lot of the hands-on care, and the doctor comes in to check. I don't think that's surprising in and of itself. However, there was no sense that this was an actual medical discipline. That comes much, much later, as we're going to be looking at. So this is related to the idea that really develops in the 20th century, that from within biomedicine, death is a kind of failure. And I think this is just so unfortunate. And I was watching the Pit the other day, the show The Pit, and how the doctors are reacting when there's a death and, taking it as a personal failure. And so I think this attitude has to shift before palliative care can really be accepted. And obviously now we see palliative care doctors, palliative care nurses who are trained within this attitude. But certainly in the 19th century, we still have that idea that it's the doctor's role to cure the patient. So generally there's the idea that if death isn't a failure, then it's something that doctors aren't really concerned with. That's for the family and religion, if the person's religious. So the majority of patients that were taken into these institutions were suffering from TB. And again, many of you will know that this was a huge scourge in countries like England, again, often related to population density. And so it was the leading cause of death in Britain and Ireland. And I know within my own family, many of my family died of TB. It's very common and died very young, actually. And so TB, as you probably know, is a lingering death. And so, again, requiring this ongoing care. And so these homes have been referred to as proto-hospices, first by Golden in her article written in 1981. And so, as you can see from this lecture, we're not quite there, but we're seeing what's going to create this, what was really a movement, an international movement, and it emerges out of need, which is unsurprising, as this is how most changes emerge, from changes in culture, changes in demographics, changes in medicine and technology, and also in religion. And so we see the hybrid that will become the palliative care and hospice movement when all of these factors come together.